The Littleton Board of Health, Wednesday, September 22nd, 7 p.m. virtual Zoom meeting. We'll start right off with our public hearing on 12 Shattuck Street, a review of the modified housing order. So I don't have the names on the agenda. It said Rena
Schindler, and I think it's Karen Rose, Karen Amy Rose. Those are the two property owners.
All right.
Yep, we're on one machine.
I can kind of give you an update to this point, and then if Rena wants to jump in to have comments.
Sure, go ahead, Jim.
Okay. So as you remember, the board issued an order had some time frames. Rena actually came, and the property owners came before the board to ask for an extension of time, some of the construction items. Board did grant an extension essentially till September 1st. I think the assumption was, or I'm not sure how it was going to play out, but at that point, the tenants may not be in the unit because some of the work needed to be done. It was more of a heavy duty construction nature, and it'd be better if they weren't people in the unit. So with that being said, I went back and re-inspected the unit on the 27th of August and the 3rd of September, just to check and see if the compliance with the board's order had been met. And there were issues that hadn't been done. Reissued a letter to the property owners, a copy to the tenants, kind of outlining what was done, what wasn't done, and that I was going to put the matter on the agenda for the Board of Health to decide what additional enforcement mechanisms that you wanted to take. Both the tenant and the landlord have concerns about access and being denied access. And again, we have the information from both of them. I understand it's sometimes difficult to match schedules, particularly with lots of different contractors. The timelines have passed. I know the matters in the housing court, which isn't really anything for the board to deal with unless you decide you want to refer the matter to housing court for the court's help in enforcing the order. My recommendations at this point is I haven't been back in the unit since the 3rd. I certainly can go back to the unit, take a look and see what has and hasn't been done based on the order. And then, again, the last time I sent a letter out, I think I sent Department of Public Health has a memo, for the lack of a better term, that describes what reasonable access means. So whenever you do a housing inspection, tenants and landlords have to work out the access to the unit for corrections. So Department of Public Health essentially has an interpretation, I guess is what it's called, for what reasonable access means. And I've provided that to both parties to try to make sure that they understand what's expected of them in this process. So I certainly can review that again. We can try to get an updated date for completion. If that doesn't work, the board could certainly ask council to refer the matter to Northeast Housing Court to provide enforcement mechanism for this. My recommendation is to go back, re-inspect, talk to one of the owners is here tonight about time frame in which they believe it can be done. Go back and check and see if that's the case before you actually go to court with it.
Go ahead, Kevin.
Correct me if I'm wrong, but were the tenants supposed to be vacated by September 1st so that or earlier than that, so that the owners could go in and correct any issues that
need to be correct?
I guess I'd let the owners here, let her speak to that.
Hello, yes, thank you. My name is Rena Schindler. I am the landlord of 12 Shattuck Street. And yes, we had issued a 30-day notice to quit to the tenants with a date of September 1st to leave the unit so that we could address repairs that could not be done with them in the unit, like taking up the floors so that we could address the floor joists. There's some issues you'll notice of sagging floors on the violation list. So yes, we have issued them that notice to quit. They did not leave the unit on September 1st. So we are currently pursuing the matter with the housing court.
So Jim, can we make a recommendation that the the tenants have to vacate so we can get in there and correct these problems?
That's not, I mean, in the housing code, the assumption is that, the violations are there, they need to make corrections, whether it's working around schedules and that. So vacating usually isn't a mechanism the board has to get the corrections done. In extreme cases, if it was an emergency condemnation, obviously you'd be moving people out, but otherwise the assumption is that the work gets done.
Around the tenants.
Essentially, yeah, I mean, for lack of a better term, yeah.
So we did request the extension last time for September 1st on the assumption that they would be out. We would really like to request an extension for the flooring issues. It's just that we're not sure what that date would be. It might be 6 to 8 weeks from now. I have no idea.
And furthermore, I can give you updated, well, we have updated dates where we would hope to address some issues based on availability of contractors. For example, the windows, because this is a historical house, we're looking for a historical window specialist, and they are booking 8 to 10 weeks out, and we've already had to reschedule them twice. So it becomes difficult to reschedule these when we don't have easy access. But we can give some optimistic timelines, assuming that our motion for a temporary restraining order for access, which we are hoping to acquire on Monday, assuming that works, then we could give some optimistic dates for when we expect the rest of the work to be finished.
Go ahead, Mike.
Yeah, I have a question mainly for Jim, since he wrestles with this, sort of. It sounds to me like some of these, shall we say, corrections and repairs are extensive enough so that the tenant would literally have to stop living in the unit during the time of the repairs. So that's the assumption I'm making. As a general assumption, it may not apply to all situations. Are there, to your knowledge, any built-in obligations on the part of the owner to tenants during, shall we say, necessary repairs in order for the housing to be safe? In other words, if there is, does this only occur in land court where such an action might be taken, where the landlord is required to, as it were, provide resources so that tenants can live while their apartments are being fixed and they don't have access to them? Or is this something that would fall in our purview?
So again, I'm not sure, I'm not a contractor. So the only work that's, to me, kind of questionable as to whether the tenants could be there is that floor along the wall on the Shattuck Street side of the house, and whether, whether there's some arrangements that couldn't be made so that the work could be done and tenants could still have access. There are 2 doors in the front of the unit, so you have a couple of egresses, although one of the doors now is boarded up and probably should have stairs put under it so they could, they took the deck off the house and now there's a door with a board on it. So I don't know that, and again, I'm not a contractor. I'm not sure that we're at a point where they necessarily would have to exit the house to do the work. I'm sure it would be much easier to have nobody in the house. I just don't know what's entailed in fixing the underneath of the floor.
No, I understand that. I'm asking, I guess the way I probably should have said it, if is there any requirement, if someone is renting a space, as these folks apparently are, is there an obligation on the part of the owner to make sure these folks have a place to live in the event, for the convenience of the repair and therefore for the owner? In other words, who takes care of the tenants when they're being asked to quit?
Well, my thought is they have a unit that they've been rented and should be habitable. I know in some cases, such as lead paint, there are times where landlords put people up in hotels and that, because in those cases, people really can't be in the unit while they do de-leading units. So there are examples where landlords have been responsible for putting people up. The only other example I can think of off the top of my head, it's kind of an extreme situation. If you're doing, extermination and have to, bomb a place or something like that, you need to have people put up. But again, this is one of those things where, again, it would have to a discussion with the contractor. can this work be done? Can it be phased in while the people are still living there? Can we make accommodations for that?
And it seems also there's a timeline here because they have to hire a specialist apparently to do some of the work. So there's a lot of, shall we say, moving parts to this.
Right.
That makes scheduling around someone living in the unit even more difficult for both parties. All right.
But I think getting a schedule from a contractor, then you can essentially go back to the tenants and say, hey, this is the timeframes in which we need to have this unit.
So we gave a modified order for the tenants to be out on the 1st, and they're not. So are they going to be renting or signing a lease after the work is all done, or they have a current lease?
No, so we gave the owners a 30-day
extension
to get the work done by September 1st.
Okay, all right.
And it seems like at this point, the tenants may be there for quite some time until, an eviction moratorium gets lifted or they vacate.
Well, just to clarify that, the eviction is not based on rent, so it is unrelated to the moratorium. The eviction is specifically for the reason that we need to do the work. It's a no-fault eviction. They were advised in June that we would want them out by September 1st. They have had more than 60 days to September 1st.
Right, but it sounds like you're going to court. And it sounds
So we're going to court.
So
yeah.
if I could just make a suggestion that in the next 2 weeks or 3 weeks before our next meeting on October 13th, you line up contractors and get a timeline in place. And then you're just going to have to work around the tenants.
That will work if our restraining order goes through. We've had some issues. Yeah.
The tenants have called the police on us just for exterior looking. You'll notice in the violation, there's rotting soffits. And the front door has to be repaired. So we had a contractor there. We were looking at the exterior and the tenant called the police. Obviously, the police said we were allowed to be on the property, but that's an example of some of the issues we've been dealing with trying to get this scheduled.
Yeah, they sound lovely.
Yeah.
May I make a motion to continue this until October 13th so we can get a timeline from Ms. Schindler on a contractor's completion of the work?
Madam Chair, there's public comment.
Anybody from the board have a comment or a question for Jim or the landlord?
Just a quick question for Jim. We obviously have your initial letter. I don't remember seeing a letter outlining your findings on your re-inspections. If you could just share that with the board at your convenience, just to see what work has been done and what is still outstanding, just so we have that sense of where they are.
Sure.
Thanks.
Gino, did you have any questions for Jim or for the landlord? You have to unmute. Gino, you have to unmute.
Is there any way that the owner of the apartment can give a place so they can stay? Because I seem like they can't find a place to stay. That's why probably they're trying to stay there as long as they can. But the question I gave my second to Kevin is because maybe they are able to fix it while they're there. But if they can't fix it while they're there, the extension will be valid. But then they have to go to court and to say they're going to have to evict their family. I feel bad. What happens if they can't find a place to go? That's the problem. That's the problem. See if we can help in any way those family too, and the owner, because I know she likes to get it fixed. I understand the situation. I feel bad.
All right, Janet, you said that there were people with their hands raised.
Yes, there's Martin and Chad.
Martine and Chad, actually. We are
I'm
the
sorry.
lovely.
If you could state your name and address, please.
Martine and
Chad Kibbe, and the address is 12 Shattuck Street, apartment number 1, bottom floor, in Littleton, Massachusetts, 01460.
And are you folks the tenants?
Yes.
Mhm.
Go ahead.
In the interest to be brief, there's several things. But first of all, I was unaware that a historical contractor had to work on the windows. There have been people that were scheduled to work on the windows. There was scheduled work to be done for an entire week, and that handyman walked off the job at noon on that Monday. So I am uncertain and unclear why they have filed some sort of restraining order against us to allow access. We have allowed 20, 30, even 40 appointments that are canceled, that are rescheduled, that are shown up at different times. People have showed up at our house without an appointment. We have let them in without knowing their names or numbers.
People are showing up at all hours of the day and night, walking around the yard. It's getting to be more than scary. It is becoming a frightening situation, and we're kind of worried about, what's going on here, who they're letting in. Some of these people have gotten outright belligerent with us.
They're being very rude to us. They won't speak to us. We're being treated like pariahs, and it's caused extreme anxiety issues. I've never had anxiety attacks in my life. And
Rena and Karen Amy have contacted us more than, I think my wife counted, more than 60 or 70 times over the past couple months.
65 emails alone the last 2 weeks of July, and I couldn't handle it anymore. We hired a lawyer so that they could go through our lawyer and arrange all of these appointments. We thought if they could go through our lawyer, perhaps people would actually show up when they were scheduled. They harassed our lawyer so much, she actually quit.
We have spent, we've been trying to find a place to live, but with our animals, the situation that we're in, and the ladies were very kind to let us stay here. But it's very difficult for us to find another place. And we've been looking, but it's hard for us to look when we have to move all of the furniture into the center of a room in multiple rooms, sit around and wait all day for a contractor to show up that doesn't even arrive. And whenever we respond to them and text them and say, hey, where's this person? They just say, oh, they'll be there soon. Be there soon. And they never show up.
Okay. All right. I think we understand what's going on.
I kept it, and I've sent it to James last night, and I sent it to the Board of Health email. We have documented all the times we've allowed access, all the times people haven't shown. I keep impeccable records. As far as the floors, we've lived with these floors since we moved in. The floors have been rotten for 3 years. When they showed us the house, they pointed at the floor and said, be careful where you walk or you'll go through the floor.
With the stove, they said they would have to replace it in a month.
Anyway, obviously we are very frustrated, and we've done everything we can to help them with repairs.
Okay, love.
Yeah.
Let them have their space.
Okay. All right. Thanks for your comments. Any questions or comments? Anything to add from the board? Rena, I don't know if we want to even get into this. So we have a motion to continue this discussion until our next meeting on October 13th. And I think it's very complicated with these folks, with the land court and not court, but court and restraining orders. And I think we need to revisit this once they kind of clear things up amongst themselves.
If Ms. Schindler could please bring with her a contractor's schedule to complete the work at our October 13th meeting, I think that would be a step in the right direction.
I second already, didn't I?
Yep, you already did. Yep.
I feel
Right.
bad for the situation.
Mike, you're muted.
I'm sorry. Do we have to provide an extension of time in order to allow the landowners to, as it were, put together the schedule, and or is it simply come back on the 13th? Because it sounds to me like everything gets frozen.
Well, I think, Mike, a lot of it depends on what happens on Monday, if they get the restraining order or not, and are able to access the property as needed.
Excuse me, by the way, the contractor, they should notify when they are able to go and see what they can do the work. not say they're gonna be there and then they're not gonna show up. I can see why the family, they're getting upset. I feel bad for the owner too. But the question is, something's gotta be done.
So right now, it appears that the owner, as the recipient of the order of correction, is in violation of that order. The repairs have not been made or a timeline has not been provided by the September 1st deadline, which would mean they're in violation of our order. I would say if we don't grant an extension, then theoretically they're subject to daily fines for failure to comply with the board's order. So again, I don't want to be the mom and dad in the middle of the two kids fighting, because this is not going to be solved here at the Board of Health. However, there is an order for correction that's out there that is within our scope. I mean, I think without trying to adjudicate who is right and who is wrong in this one, which we're not going to get to, I think a extension grants both the owner and the tenant an opportunity to correct this without town or board penalties around that seems pretty reasonable.
Right, so can we modify your motion, Kevin, to extension to the 13th? Do we want to?
Well, they won't be able to complete the work by the
6th. Sorry.
6th. Okay. Well, they won't be able to complete the work by the 6th.
It's the 6th. It's the 13th.
13th.
October 13th.
But if they come before the board the 13th with at least a written plan and contract, which I think is also in the order, they had a 30-day window to, if not correct, then to at least have contracts and timeline, then that would not meet the needs of the order, but at least that piece of having a plan within those 30 days, which they've now had 60.
So I'll make a motion to extend our order until October 13th.
I second it.
Does that sound okay, Jim?
Yep. That right there, as Dan mentioned, that moves the goalpost out a little bit. That gives you an opportunity on the 13th to say, so what are the plans? The board can then decide if a further extension is appropriate based on the plan that's put forward on that night.
Okay. All right. So we have a motion and a second. So I'll go by roll call. Kevin Baker.
Kevin Baker, yes.
Gino Fratelloni.
Yes.
Dan Kane.
Dan Kane, yes.
Mike Zeldin.
Mike Zeldin, yes.
Lisa Flanagan, yes. All right. So it's 7. Okay, we're a little behind. We're for the 7:10 public hearing on Wellington, the deed restriction request from Steve Marsh. You guys can elevate Steve to a panelist.
He's coming. There you go. Steve, you can unmute.
Great. Good evening. Steve Marsh and Jim DeAugustine for Wellington Drive. We're here tonight based on the information that we received at the last Board of Health meeting with regard to a deed restriction to add one room in the basement of Lot 5 Wellington Drive, or 5 Wellington Drive, Lot 3. So that's what we're here for. We submitted some plans to the board. We also met with the building inspector and met with our architect to discuss reconfiguring the room so we can comply with Title V in the local Board of Health regs with regard to the extra room. So we've done that. We did meet with the building inspector and he did comment on the town's website with regard to room counts. So all we're asking for now is just the one additional room in the basement.
And Steve, do you have your plans that you can share at all with us?
I submitted them. I don't have them on to share on screen, but I mean, I can hold them up like that.
Yeah.
No.
All right.
No.
Okay.
You got to come prepared, Steve, to this is be professional now. Come on.
Okay. All right. Well, we submitted them and had them reviewed. So we're asking for one additional room in the I submitted them to Janet, I believe.
Right, but usually,
Yes, and I asked you to be prepared to present, share your screen with the board. That is how they look at them.
Yeah.
Oh, okay. All right.
Jim, did you have any comments? Jim?
Sure. So I looked at the plan. So there was the original plans that were up on the building permit site that showed kind of the maybe 3 rooms being configured in the basement. And then I noticed that plans were added. What's today, the 22nd? I think they were added today. The new plans were added to the building permit website. And they show the downstairs space now just being one big open room, if I'm reading the plans right. The only other concern I had is there's now a laundry room on the 1st and 2nd floor. It looks like the office that was on the 1st floor is now labeled a laundry room. There's also a laundry room on the 2nd floor. So I guess my concerns, recommendations, how you want it, is that clarify that that laundry room setup, because that'll make a difference in the room count. Maybe a little more detail about what the basement's going to turn into. Sometimes, and again, there's a little bit of judgment that goes into trying to make these determinations, and I never doubt how people want to use their houses. I always tell people it's more about how the house is going to be passed on to somebody else. What is somebody going to say that the downstairs is in-law ready, or so those are always my concerns. So sometimes if you have one big open basement room, it looks like kind of straight face, it looks like just one room. Sometimes if you've got spaces that could easily be closed in by a door, all of a sudden you're wondering if you've got a couple of spaces. So in this house here, looks like a family room with a basement, so there's kind of a separate space. So again, some detail I think would be helpful to try to discern. I don't necessarily, if it's one additional room over the Title V count. So this is a 4-bedroom design. 9 rooms are allowed anyway. If there was 10 rooms in this, the board used to have an old policy, and I'm not sure where it is anymore, that for one extra room above, as long as it wasn't a bedroom, the board would consider a deed restriction. I don't see an issue with that. I just think we need some clarity in the design so that we know what we're approving.
All right, any questions or comments from the board?
Will allow a deed restriction
Are there two
on one
laundry
big
rooms?
open room?
Sorry, Gino, you had a question?
Yes, will they allow the deed restriction in one big room downstairs instead of to have any doors or closets, just an open room? Maybe they can have a deed restriction, and then they should have no problem, as long as they use it only for one big room.
If I may, we only have one big room down there, and then we're adding one room. We're already in compliance with the 9 rooms. I don't need to talk to the board. I'm asking for one additional room.
I understand that.
So I'm asking for the deed restriction, and typically what happens is that, so for example, up on one of the other projects, when the homeowners come in, they get these granted, almost carte blanche. We're doing it, right up front, right out of the gate.
I understand.
And the homeowners come in and do it.
So just if I could, Lisa, I think we apply the same process with the homeowners as we're applying here. They submit plans, we look at their floor plans and make a determination. The board does based on the room counts of the existing house and what they're proposing. So I don't think there's anything different in the process.
Okay, but we're asking for one additional room, which is typically granted. So,
Right.
Madam Chairman, I have a.
Sure, go ahead, Mike.
Sorry, I just want clarification. According to the comments of Jim, who's actually looked at the current plan, he said detail was missing. So this is as far as
what kind of detail is missing? Everything's on the plan. It's been
which you'd happen not to bring. Okay, so as far as I'm taking. I looked at the plan that was provided, and I have to admit that I can understand Jim's concerns about things not being clear. And I don't think that this is one of the. Excuse me. Could you excuse me? Okay, I'm trying to say to do this properly, there should be clarity that satisfies the agent who acts on behalf of the town to make sure the plan reflects accurately that when you quote add the extra room that there is basically it's done properly so our deed restriction can be, shall we say, defined.
Sure.
Okay, period. That's all. And at the moment, it appears that clarification is missing. And that is, it has not been presented to the board. There's nothing in front of us. And other than your insurance that everybody else gets it, so why you can't? So I mean, Jim, is it unclear to you what's going on here?
But again, I mentioned there's laundry room on both floors of the house. One of those laundry rooms, the one on the first floor, used to be the office in the old plan. So
Yeah.
just clarity of how rooms are being set up. And then in the basement, when you go down the basement, and Steve, correct me if I'm wrong here, you go down the basement is the main part of the house. And then there's, I think, a family room off to the right as you're facing the house. And that looks like it's part of the finished space too. That's why I guess I'm not clear about how that space in the basement is being finished.
Right, the exterior walls on the basement are being finished. I met with the building inspector, and there are no windows or anything under that side of the house. So that's not, they basically want to put in a gym, a gymnasium, and a prayer room in their basement. So we comply with the 9 rooms. We're asking for that prayer room is what we're asking for. The board at the last meeting asked me to take a look at the plans to see if the board's the one struggling with this, as far as I'm concerned, because we can accomplish, we're asking for 1 room. That's it. We reconfigured the rooms. We added or reconfigured the rooms and made it a laundry room. It works for these people. And then we're in 100% compliance with Title V in the local regs. And that's what we were asked to do. That's what we did do. I apologize for not having the plan here. We're kind of new to the Zoom thing too, and every town that I'm working with is different. Some want the paperwork sent, and I apologize for that, Mike. But again, we're only asking for 1 room. We're already in compliance with the 9 rooms.
I don't believe last time we talked about these rooms off to the side with the no window and then finishing the basement for a bathroom. I thought it was just going to be 1 big open space.
It is with a bathroom, correct. Bathrooms and laundry rooms don't count. Again, so in order to take your words or the board's words, and we looked at it, we scrutinized it and said, okay, in order to be in compliance with Title V and your regs, what do we have to do? And we did that, and we've accomplished it. So again, we're asking for 1 additional room, a prayer room, essentially where that's going to be basically a big gym for their kids.
And I'm looking at the plans that you sent, and over to the right, there's an existing concrete wall, note no windows.
That is correct.
And what's that?
That's part of the structure. That's just part of the structure. It's just space underneath the.
It looks like it has a doorway.
But it's not a door. But it's not a doorway. There's no door. There is no door there. Nor is one proposed. The house is going to be inspected at the end anyway, probably by Mr. Gareffi and the building department. They'll validate that we're building exactly what the plan is.
Go ahead, Kevin.
Is the laundry room upstairs or downstairs?
There is a laundry room on the first floor and on the second floor. There are 2 laundry rooms, and laundry rooms don't count.
Right.
And neither do bathrooms in the room count.
I know that.
I know I've dealt with this in other towns, and and I know you probably don't want to hear this either, and just like, you gave it to other people. But the reality is, things have changed with this COVID thing, and we're trying to accommodate people that want to, they're stuck in their houses. We don't have a lot of yard space on this project either.
Madam Chair.
So,
Madam Chair, may I make a motion? I'd like to make a motion for the developers to submit a set of plans that Mr. Gareffi is comfortable with. And if that is the case, then allow the additional room with the deed restriction.
Does anyone want to second that?
I'll second that.
Okay. So, Mr. Marsh, if you can get Jim a set of plans that he is comfortable with. Jim, are you okay with that?
Sure, I think I have a sense of the board, so.
Okay.
We will do that.
All right. With the detail and, listen to Jim and see what kind of detail he's looking for. And so we'll take a roll call. So Kevin Baker.
Kevin Baker, yes.
Gino, you're muted.
Gino, yes.
Dan Kane.
And Kane, yes.
Mike Zeldin.
Mike Sullivan, yes.
Lisa Flanagan, yes. So if you're all set with that, Jim,
Okay.
that would be great.
Thanks.
Thank you very much. I'll reach out to Jim and I'll get him exactly what he needs. Thank you very much.
Thank you.
Have a great evening.
Thank you for coming.
All right, a little late, but our 7:20 discussion, the COVID-19 update with Jim and Katrina. Is Katrina here tonight, I hope? Yes.
She's on her way in.
Thank you. All right. Jim, would you like to start or?
Sure. So, kind of taking it was kind of a sneak peek at the numbers ahead of time. We're kind of staying in Littleton, staying about the same numbers. Again, I think I came up with like 27 numbers that came from the state kind of previewing it said 28. Last week, I think it was 29. So you're right there. Again, we'll see what the state number brings tomorrow, but again, it's going to be in that ballpark. So things really haven't changed a whole lot. They're staying at that level. We are getting a handful of complaints about the masks. I go out and do the education piece of it. I think I had mentioned to the COVID advisory group on Monday that the gas stations seem to have bigger challenges in so much as they're a little more transitory locations, so people are coming in from other towns. So I have suggested to those folks that they put signs further out, either on the pumps or further out from the entryway, just to kind of facilitate compliance with that.
Good idea. Yep.
So I'm following up with them on that. I try to go to places at different times. The times I've been, the supermarket's the other big place where we get complaints, and I follow up with them and try to check first. 100% no, but boy, they're working on it. And the times I've been in there, they've been pretty close. So again, a work in progress.
Right. I think that first week we had a lot of people complaining about it, but there is a learning curve, and I think it's a surprise to some people that Monday they didn't need one, or Labor Day they didn't need one, but Tuesday they did. Right. So I think that first week there was probably a lot more than we're going to have. Hopefully, people get notified a little bit easier. Okay. Anything else, Jim?
That's it. Yep, that's it.
Great. Did any more clinics or anything like that you see on the horizon for Neshoba to perform?
So all of starting the end of this month and going through the entire month of October, we've got flu clinics scheduled in all the towns. So, and again, we're kind of waiting to see what the information on boosters are going to be. I think I did mention that the state surveyed all the boards of health to see if they would be willing to do boosters if and when and we mentioned that we would be, but we certainly wouldn't be doing them until they're approved and how they're approved. So we need to get that information, but also after flu season, because that's a big focus in October.
Right, because, okay, go ahead, Mike.
I have a quick question for Jim. Maybe I've asked this before and forgot it. Sorry, Jim. Is there any estimate coming from the state about the number of cases, either at the town level or the county level, where the number of folks who are reporting as cases are vaccinated, either partially or completely?
So to the extent that we have that information, so when a report comes into Maven, I think it pulls. So if your vaccination rate is vaccination status is in the MIIS, so more acronyms, I'm sorry.
That's okay. Yep.
It's the state's vaccine database. Yep. So anytime you get a vaccine, particularly if you're a state or using state vaccine, you're required to put that information up there. So when that information's there, it pulls into the record. So you probably, when we get cases, about half of them we don't have vaccine data on. But for the ones we do have vaccine data on, there's enough people out there who are fully vaccinated who are still coming down with COVID.
Okay, this is an important point.
Yeah.
Really important point in how we view the numbers. I'm glad that you provided this because I wanted other members of the board to hear this.
Yeah.
It sets the context for what's going on. Thanks a lot, Jim. I appreciate it. And anything you can find out, from the official data flow, even if it's delayed, is helpful. It gives us a picture of really what's going on and how it matches up with the vaccination rate, which apparently in this town is still very healthy, and I'm glad to see that. So thank you very much.
You're welcome.
Go ahead, Dan.
Through the chair to Mike, actually, it's not a great metric, but if we look at hospitalizations, the state's dashboard, when you look at the hospitalizations, actually provides total hospitalizations. It also includes the number of those hospitalizations who are considered fully vaccinated. And right now, so as of yesterday's numbers, we have 618 COVID positive patients in hospital. 209 of those are considered fully vaccinated per the state's dashboard. So, and that number, that ratio has been about steady for at least for the last few weeks that I've been tracking it. So it's a lot bigger than I would have guessed. About a third of the patients are fully vaccinated and yet sick enough to be hospitalized.
Thanks, Dan, for the reminder. I'm just looking at spread. So, yep.
Okay. Go ahead, Kevin.
Jim, I was speaking with someone at the MAHB, and they had mentioned that the CTC was going to be scaled back and possibly even discontinued in December.
Yeah, we're kind of dreading that.
Yeah.
We're hoping the cases drop significantly because, I mean, 40 cases came into the office today. For the
and how many? And how many did you ship out to CTC?
Most, because we just, in addition to this, we're dealing with the schools who have exposure in the school and handling rosters and trying to get those rosters up into Maven. So there's a lot of, and then just the questions from individuals, sports teams. That's the other thing. Not school sports teams. Your local club type, the town league. So we're getting those questions too. We've not in Littleton, but we've had a couple of hockey exposures already that we're dealing with. So there's a lot of moving pieces here. So we have the state, I think CDC gave the state money to provide communities monies to hire additional contact tracing staff. We have that. We applied for the grant, got some money. We've interviewed one nurse. We sent an offer. We're trying to get another nurse so that the idea is that by the time CTC kind of wraps it up, that we'll have some additional staff on hand to be able to do more of that in-house. And again, I know CTC was supposed to end, like September, I think, but with that huge surge in cases, they kept them on. I guess I hope the state looks at caseload going forward and it keeps an open mind about that.
And Kevin Davis, I think, is going to speak a little bit today about the exposure notification app. So I don't know if that'll help your cause at all, or how to implement that. But maybe just think on it.
Yep.
Okay. You ready, Katrina? As ready as you'll ever be.
Am I ever ready? All right, you guys can see my slides, right?
Yeah.
Thank you. All right. So in terms of transparency, I did this at the school committee meeting a couple of weeks ago. So I just want to be clear. So I my background is I have a master's in public health from BU and a bachelor's of science in biology from Bates. I'm currently I do research on disease epi and pharmacoepi at the Boston Collaborative Drug Surveillance Program, which is a not-for-profit research group in Lexington. I've been there for 14 years, and before that I had 6 years of experience in clinical trials. And just so everyone knows, I am a Littleton resident. My kids are in school, so those are my conflicts, but I don't have any other commercial, financial, or legal conflicts to declare. And all the data I've used in any of these presentations come from Mass DPH, CDC, or the school's local website. So we go look at some data. This is the dashboard for today. Again, this is Wednesday, so the new rates come out tomorrow, but I'm trying to give you as much updated stuff as I can. So it comes from today from the state. Things have been holding kind of steady over the last few days, and so we're going to dig in a little bit into details, but overall things are holding. Testing actually has, over the last 6 weeks, has increased substantially. Actually, some of this is due to the colleges and universities returning and continuing their testing programs of their students and staff. There's actually more antigen tests being conducted too across the state. So those antigen tests tell you if someone is contagious now. So that's kind of nice to see that that's happening as well. And test positivity across the state is 2.1% today. And then if we look at cases over the last 6 weeks, cases kind of just kept steadily ticking up over August and into the beginning of September, and is now kind of leveled off for around 1,200 cases a day, I believe, that are being reported. And then this is data actually from last Thursday on 9/16. So every week, when the town data comes out, the state also gives us a snapshot of age groups of cases. And then I've been graphing them over time just to look at trends. So all age groups continued to trend higher in terms of cases over the period of August 29th to September 11th, which was that last reporting period. 20 to 29-year-olds, 5 to 9-year-olds, and then 30 to 39-year-olds currently had the highest rates last week, and they're all over 400 per 100,000, I believe, at this point in time. So those are the top 3 categories, if you will, but everyone has continued to go up. And then kind of digging into that hospitalization number that was mentioned a few minutes ago, Mass averages about 675 people who are admitted to the hospital for COVID per day, or in the hospital for COVID per day. So just to be clear, the Mass DPH definition defines COVID hospitalizations as those whose reason for being in the hospital is COVID, and they explicitly exclude individuals who are admitted for other reasons and then test COVID positive incidentally after admission. So this isn't just testing everyone who's in the hospital when we got cases. This is those admitted to the hospital for the purposes of COVID. So today's report also indicated that 91% of medical and surgical beds are in use across the state, and 79% of ICU beds are occupied. These occupancy levels that the state reports actually measures hospital capacity, not beds in use just to COVID. So those 675 beds are a small portion of all of the beds in Massachusetts, but a lot of our beds are in use. And coming this close to capacity is concerning, because that means some individuals who go to the hospital for any reason may have to wait until a bed is available. So the capacity is a big concern in terms of caring for people for all reasons. And COVID is preventable. So anything we can do to keep cases from going up means that we're kind of preserving our healthcare access. I know those hospital workers are very tired at this point. So COVID deaths over the last 6 weeks, the current average is about 9 deaths per day. The rate actually increased over August and to the beginning of September, and is now kind of stabilized at this 9 per day rate over the last 2 weeks. And that's 9 per day. So multiply that out every day. It adds up quickly at this point, but hopefully we can get it back down to those 1 or 2 that we were having earlier this summer. Okay, and this is the CDC community transmission rates for the period of September 14th to 20th. I downloaded this today. Middlesex County continues to be classified as a high community transmission area, as does Worcester County. So we are surrounded, our entire state is red. And that said, when you look at the actual rate, it's been around 130 per 100,000 for a week or so now. So this is actually holding steady over a period of time. It's not it's not quickly going up. It's also not quickly dropping. We're just kind of steady state, which matches the rest of the case data we saw earlier in this presentation. All right, so digging into some Littleton data. This data is coming from last week's DPH report last Thursday by municipality. So last Thursday, it was reported that Littleton had 29 cases over the 2-week period of August 26th to September 11th. And that, as Jim had said earlier, was a similar level as we've had for 3 reporting periods. So we are kind of hanging out at this high 20s, low 30s number. And then Jim just mentioned that his sneak peek into the MAVEN data indicates that there is about 27 cases. So somewhere in the 27, 29 range. We're very similar to last week. So we seem to be steady at this high 20s, low 30s number of cases. We'll see tomorrow to confirm that. Okay. And then a little bit of methods, just to review these because it's been a while since I've been here. So when I do the rates, when we aggregate by towns, like for other towns, these are the town groupings that I use. And these are the ones that were identified over a year ago when I started working with the school committee back in August of 2020. Mike Fontanella actually selected them. And then the reason we aggregate over a larger area than just Littleton is because Littleton alone is really small. So a couple cases can really wildly jump our rates around and make it really hard to interpret and to see what's actually happening. So expanding our area of observation to include towns around us helps us to stabilize the rates, makes them easier to interpret, and also lets us compare areas with different sized populations. So this helps us analyze trends over time. So these are those trends. The state provides two main measures for local data. One is average daily incidence rate, and the second is test positivity, both measured over a 2-week period. The last 2-week period was August 29th to September 11th, I believe. The left-hand graph shows that average daily case rate. So Littleton's average daily incidence rate was 21.2 as of last Thursday's report, data ending September 11th. Which was slightly lower than the 2-week reporting period that was just prior to that. But essentially, if you can see it, we're like almost the same level as we were 2 weeks prior to that. So we're kind of stable as of last Thursday's report. And then over those 3 reporting periods. And then the test positivity is the graph on the right, and that is the total number of positive tests divided by the total number of tests conducted, not number of people, number of tests. And so that gives you the percent positive. And you can see that all areas either flattened or like were slightly declined over the last reporting period. This is actually, Mass does a lot of testing. This is actually one of our strongest layers of cheese because we are able to capture cases quickly and get them into Jim's hands for the test, trace, and isolate system to work more effectively. And that shows in our testing positivity because we're less than 3% for all of these areas, whereas other areas of the United States are, if you get above 10%, there are concerns that you're really missing. You're not doing enough testing for sure. So we are, in terms of the test positivity, we're doing enough testing to be catching cases. All right, so this is the CDC community transmission rate, but just tracked over time. Instead of just showing you the map, this is the trends over time. Here I've plotted the state, Middlesex County, and Littleton. All of those areas continue to be classified as high community transmission areas. We're in the red. I think this is a good example of why we tend to look broader and at areas around us, try to look beyond Littleton, because when those few, couple cases, I think there was like 3 case differences between these last 4 reporting periods, or 2, like it was just a handful of cases made our rates go pretty wild up and down. And that makes it really hard to, for individuals to anticipate and to know what to do, but also to interpret and see over time. It can be really frustrating if you keep bouncing between these community translation colors too. And I have to say, Littleton's community transmission rates are not statistically different than Middlesex County or the state. So having that broader area, which is widely available on the website, is perfectly acceptable given our rates. This is our current vaccination coverage. This data comes from the DPH and is released on Thursdays by municipality. At this point in time, 73.9% of all Littleton residents of all ages are fully vaccinated, and 5.8% are partially vaccinated. So when put together, we have 79.7% of all residents have had at least 1 dose. So we're doing very well with our vaccinations. During the last week, I noted that 16 residents moved from unvaccinated, or the not vaccinated category, into either the partially vaccinated or fully vaccinated, depending on which vaccine they received. Those were from the 12 to 15, 30 to 49, and 50 to 64 age groups. So those are great target age groups that we were hoping to see move. And then over the last month, a total, like a whole month snapshot, we had a total of 140 residents move out of not vaccinated into either partially or fully vaccinated, which is a great, really good movement that we hadn't seen earlier this summer. So that was nice to see. There remains about 7% of all residents who are eligible but not vaccinated according to the DPH data. So there are some targets still out there. Hopefully we can reach with messaging and by bringing the Vax Plus back, things like that. And then this is the Littleton Public School COVID information. Just for some history, all of last school year, Littleton on average had 1 case reported per week. And we had like 66, I believe, cases total for the whole year. Much of last year was in hybrid, and that impacted who got reported as a case also to parents and stuff. And also the number of, because we were in hybrid and most of the year was spent with more than 6 feet of distance, there were a few close contacts reported as well. So this year is a little different. Everyone's back in person. There's going to be more close contacts because of that, although the schools have a different close contact definition. But it has been the first 3, this is the first 4 reporting periods, basically. So since school started, we had no cases that first 3-day period. We had 1 case each additional week. This one just popped up tonight. So 3 cases so far in the schools, 1 at the middle school, 2 at the high school. So far, 11 close contacts have been reported by the schools, but they count all close contacts, whether they occur in the school or outside of the school. They're community close contacts, just because that's how they are supposed to be reporting them. So at this point, Shaker Lane had 4, as of last week, last Friday, Shaker Lane had 4 close contacts, Russell Street had 4, middle school and high school each had 1. And those COVID safety checks, the pooled, formerly known as pooled testing, began this week, I believe, at all schools. And if you're ever interested, every Friday, the schools publish a dashboard that you can check that week's status. And then wrapping up a couple more slides, the cheese model still needed. So we know that spread's happening, rates are high, we're in high community transmission areas. So there are reasons to try to use as many tools as you can to prevent spread amongst other people. That could be masking. A better quality and fit mask is really advised to start moving to. There's been some recent studies, which we knew, but have been confirming that a better quality or fit, like a surgical mask, a KN94, a better quality mask is worth investing in at this point over a cloth mask. If you can get your hands on any of the rapid tests that you can buy over the counter, those are great to have on hand in case someone is symptomatic or you find out you have an exposure, if you have to go out of the house to see someone else, or if you're visiting someone who's immunocompromised or whatnot. Those are great tools to have on hand just to make sure you're not forwarding spread. And then just keep going. Vaccines are our biggest tool that we need to keep working toward. And ventilation. So anything you can do outside or with windows open, eating in restaurants outside, things like that. These are really good ways to highly reduce your risk of spread. And then I want to end on a little bit more data about vaccines. So this data comes from the Mass DPH on the fully vaccinated case report. So this layer of cheese probably has the fewest holes in it, so less likely to have problems. Doesn't prevent it completely, but definitely has the biggest bang for your buck in terms of what layers of cheese to use. So here in Massachusetts, against Delta, fully vaccinated individuals have had, as of the week before ending 9/11, fully vaccinated individuals had 4 times lower rate of infection compared to unvaccinated or partially vaccinated individuals. For those that did get infected, most people had milder symptoms or shorter duration. Not all. We've just heard about some who ended up in the hospital with needing care there, but most people are experiencing milder disease than was experienced prior to vaccination. And then fully vaccinated individuals also had 14 times lower rate of hospitalizations compared to unvaccinated or partially vaccinated individuals. So in all, everything we keep seeing with the science is, I know the headlines say like 4,000 vaccinated cases, breakthrough cases came through, but I think what's not being, the headlines like those splashy titles, but what's not being shared is that your risk, even with 4,000 cases this week, the rate is still so much lower than with unvaccinated people. So there is protection there that's happening, and it's still doing a great job at preventing people from getting sick, which is exactly what these vaccines were designed to do. So I encourage you, if you are eligible for vaccines and have not yet either finished your vaccine series or have not, have not started, I really encourage you to talk to your doctor if you have questions and then go and get vaccinated. That's your best way of protecting yourself from getting severe COVID. That's it.
Great. Thank you, Katrina. Does anybody have questions for Katrina? Go ahead, Mike.
Okay, if you can, I've been trying to look it up while I was listening to your stuff. I wanted to understand, going back to the time before we had the vaccine, you can imagine that, okay. We had N number of cases per week, or maybe per month, however we want to express it, in the schools. Was that running independently of what was going on in the community at large? In other words, if I'm not mistaken, one of the success of we could only mask, keep distance, wash our hands, and be careful. Those were the days. And the reason I'm emphasizing this is that generally our actions in Littleton, which turned out to be very successful, was we took very seriously the notion if you have community spread, it's going to come into the schools. So the residents of Littleton basically did a great job, and I'm trying to see if it was reflected in the fact that, or even though the number of cases in town prior to the vaccine were not very good, okay, nonetheless, between what the schools were doing plus what the town was doing, the rate in the schools never got out of control. That's what I saw in the first two samples I saw. What is your take? Because you were actually doing the math.
So the number of cases last year, so the 2020 to 21 school year, the number of cases reported by the schools was heavily correlated with our rates in town. So the higher the rates got in town, the more cases we were finding in school or being reported among the school population. So that's separate from transmission in the schools. So all those layers of cheese that the schools worked so hard to use, and that was distancing and masking, and they evaluated the ventilation system, opening windows, outdoor lunches, all those things that they used to prevent in-school transmission were very successful. And that became very clear when pooled testing started in March, I believe it started, and we had 0 positive pools for the entire remaining school year. So that is excellent. And so the schools are currently using all of those mitigation except distancing, because they can't use distancing anymore. Right. And so far we've had our 1 case a week average, which I have to say our case rates being the CDC transmission level is 170 per 100,000 for Littleton itself. And the higher, like above 200,000 is when we started to have more cases being reported by the school. So we're kind of at that, if things get higher, we're going to be in that more introductions of cases to the school population situation. But right now we're on that 1 a week, which is manageable, thankfully, so far.
But the community aspect of it is creeping up.
Yes.
Okay.
Yeah, it's a feedback loop. So like the schools are impacted by the rates in among everyone in our community. And then if there are enough cases in the school population and there's a transmission event in the schools, then that feeds back out to the community via households, activities, any other exposures through businesses, things like that. So we're all connected. It's a big ecosystem, unfortunately. So one needs to care for the other in order for everyone to be successful.
Yeah, I was thinking of Jim's remarks about the gasoline stations that are very close to 495 and all the rest, that they're wrestling with a problem because obviously they can't control who comes in or screen or do any of those kinds of things. That's an easy point of entry. And there are lots of them around, not just gasoline stations.
Yeah, I can see those transient workplaces, like where people just run in and run out. I can see why individuals think their risk of transmission in those settings is very low. We don't define a close contact with based on timing and distance, right? So our system is not set up to identify cases that are actually occurring in those transient interaction spaces, where we are highly set up to find cases in places like schools. Because that's where we're focusing a lot of our energy.
Where you stay for an hour and there's enough resources to control crowd control. I'll put it that way. Yeah.
In terms of like concentration of unvaccinated individuals, that's a good place to look at.
Yep.
Schools are.
Yep.
And value in what they provide back to the community too. So the schools are a place we should definitely be trying to protect.
Great. Kevin or Dan, you guys have any questions for Katrina?
No, thank you. Thank you very much.
Yep.
Thanks. Great job as always, Katrina. Thank you so much for summarizing it so wonderfully.
Right. And Katrina, will you come back every other week?
Maybe you and I can talk offline about a schedule.
Okay. All right. I heard the library is coming along today too. I heard today that the library.
We finally got some of the furniture.
Yeah, I heard shelving is an issue.
Yeah, it's the supply chain with COVID has been really broken in the last. It's amazing we built the building on time, but
that's great.
We can't furnish it yet, so it's coming. It's supposed to be in the next 2 weeks. We're supposed to get shelving, so hopefully in a month or so.
Mm-hmm. All right. Will you be able to stay on and help Jim talk about the definition of close contacts, the Deci and the DPH, indoor and outdoor?
I will try.
Yeah. Any other discussion about COVID update from the board? All right.
Go
ahead, Dan.
I reached out to Liz from Elder and Human Services. Looking at our vaccination numbers, we have kind of two big, I don't want to say holes, but two areas of opportunities among our vaccine eligible population. Numbers wise, it's that 50 to 64 has the biggest group. It's like 250 or so, give or take. But percentage wise, it's our greater than 75 population, where it's almost 20% of that population isn't immunized. So I reached out to Liz, basically saying, you probably know that population better than any other individual or department here in town, to see if they had any insight. And they've actually been very proactive. They've been reaching out to their customers actively reaching out to their customers in general, and really doing a lot of the footwork that we could ever possibly ask for them to do. And their feedback is the only common denominator they found from the folks who have not been vaccinated is that it's been, they've all had advice from a loved one or trusted peer not to be vaccinated. So we've got a barrier there, which is going to be kind of hard for us to overcome, but it is certainly an opportunity to, with facts and information and trusted professionals, perhaps sharing information and working with Liz and her team to kind of address that population and see what we can do to perhaps change their minds about whether it's effectiveness, whether it's safety. I'm not sure what, and obviously it's kind of beyond her staff's kind of piece of digging that far into the weeds of what exactly, other than that's been the commonality they've noticed. So from our perspective, from Jim and his team's perspective, doing outreach, and as we work with other human services, it's going to be accurate information from trusted voices are probably going to be our biggest opportunity to increase our vaccination numbers for their safety and for everybody's safety. So.
Right. Katrina sent me an email and we talked a little bit about it at the COVID working group that we meet with on Monday. And yeah, we're shooting around ideas about how and who we can get to talk to these folks in that certain age group. And if a pastor or a priest or something like that maybe there's also, Gino, I don't know if you work with Council on Aging. I know if Barbara McCrae or you could do a PSA and explain things, or what do you call it? I know it's a different age group, but an athletic director, coaches, captains of sports teams, things like that. So any ideas? Okay, we'll think about it.
I think those are great ideas, to be honest with you. Again, I think just also friends just asking, like trying to open a conversation and being open to the responses, because I think there's a lot of reasons behind it. And that doesn't mean that people won't, it can't be done. It can't be convinced or change your mind, but it does take care and, empathy basically to reach out to people and realize you're not going to get everyone. But Liz has been doing a fantastic job reaching out.
Yep. Okay. So we're going to move on to the definition of close contacts, Deci and DPH, indoor and outdoor, if you wouldn't mind, Jim.
Great. Talk about a heavily nuanced process. So I think the important thing is, and I think it helps the rest of the conversation is, and again, explained in Deci's protocols, is the definition of a close contact hasn't changed. It's been modified a little bit as we have vaccine, as they've got information about outdoor. So right now, it's still, if you have cumulative exposure less than 6 feet for more than 15 minutes indoors to somebody's tested positive, you're considered a close contact. Now, the Deci protocols, now, if you look at the quarantine information that DPH has, if you've had COVID, if you actually had a case of COVID, and you're still within that 90-day period of having had it, you don't necessarily need to quarantine. If you're fully vaccinated, they've changed the language a little bit in the state document to say, yeah, you don't need to quarantine, but they recommend that you test 3 to 5 days. CDC recommends that you test 3 to 5 days after your exposure and monitor for symptoms for 14 days. So those are the kind of more global community ones. And then DPH and Deci have in their protocols provided exemptions to the close contact definition. So I think, I hate to say it's a semantical kind of thing here, but that's what it is. You're still a close contact, but for the reasons that have been explained to me is that because I've been asked the question and asked to ask the state about whether community close contacts could be part of test and stay. And the documents from Deci and DPH say no. And the information I got back from the Department of Public Health is the reason that Deci and DPH felt that they could provide these exemptions was that they had a somewhat more controlled environment in that you can control things like the ventilation, where the kids sit, the fact that the kids have masks on, the fact that you can kind of control them during the day. And the other big thing, which I hadn't thought of until the DPH said, is that you could also do contact identification a little better, because you essentially know where kids are sitting for the most part when those contacts are happening. So for the reasons that you've got a mitigated situation and that you have better handle on contacts, DPH and Deci have come up with these exemptions. So students that are 3 feet or more from one another, as long as they're masked in the classroom, are considered, they're exempt from the close contact. So if you're less than 3 feet, you can participate in test and stay, which is the state's testing in school if they're doing that. Bus contacts, again, if they're masked, which is federal law, and the windows are open in the bus, they're not considered close contacts. Outdoors, so if they're doing recess, they're not considered close contacts. Although the state, part of the MAVEN team was on the Department of Public Health call for the health departments, and they even qualified outdoor exposures. And to me, the one that best sticks in my mind, if somebody was said, geez, our rugby team was playing and one of the person tested positive, I don't care that you're outside. I've seen the rugby play. You're close contact. So I use that as just a graphic for people to kind of get a sense that, and what the EPIs were saying from DPH was, even though there's, you may look at the outdoor setting, there's, take sports, for examples. They said, take a look at what the kids are doing before, the people were doing before and after the event. Were they carpooling? Are there sleepovers? Are there other activities where they may have been close together? So, but generally speaking, outdoor exposures aren't considered close contacts. So again, this is an extremely difficult thing to explain to parents, because even though you may not be a close contact because you're exempt, because you sat 3 to 6 feet from somebody in a classroom, that exemption really applies to the school setting. DPH would really want those persons to be quarantining when they're not in school or not in school activities. And that's the piece that gets to be hard to explain to people, because they kind of look at you cross-eyed when you're going through this protocol, which I have to say the school has actually put together flowcharts to be able to explain that. And if anyone who's read the protocols, if you don't have a flowchart, you're constantly flipping back and forth between pages to try to figure out, are you this, are you that, are you this? So that's really kind of the lay of the land for close contacts. And the Deci DPH protocols kind of spells out all of the different things you need to do, depending where you sit, where you fall within that, whether you're exempted or not. And I think it bears saying that it is really important. And again, we still hear it, that if somebody's got a sniffles, if somebody's got mild symptoms, really do some testing before you send a kid or even a person to work. Particularly with kids, the symptoms we see are mild a lot of times, and they're not always the ones you might say. So if you look at the Deci protocols, they have the main symptoms that they'd look at. There's like 4 main symptoms, mostly respiratory, upper respiratory. And then they talk about other symptoms like nausea and vomiting if you have some other kind of symptom. Sometimes that's all you might see in a kid is just one of those symptoms, and they may test positive. So again, parents have a better sense of how their normal child's behavior is. And so if it's a symptom that's out of sorts with your child, that may be enough to bear having the child tested. So again, I don't know that we can do too much testing, but I think we're spending more and more time trying to think more closely. Could this possibly be because kids? We're seeing more kids, particularly in the last couple of weeks, in the number of cases we're getting, and whether the Delta is hitting the kids harder or just hitting people in general harder. To me, it's just that point that what is your health condition, and really pay attention to it, make the best decisions based on that.
Yeah, it sounds like a case by case. You have to keep everything and think about everything.
I don't know if that answers that. I mean, it really is very nuanced when you're looking at, and again, when this was first introduced to all of the health agents back in August, I think we were all like, what are you talking about? I can understand what's trying to be accomplished with these protocols. I really do. And from a kind of functional standpoint, if you can get people kind of sitting at rest with their masks on, with the windows open, 3 feet apart, I think that's a lower risk setting than lots of other settings. So you can understand why they may have exemptions for some of these situations. But for those folks who don't like nuance unless it works for them, they don't really kind of get this. And I think the schools have been such a bright spot in all of this as far as community protection. They really have a finger on the pulse of what's happening in the community, and they really work hard to make sure they're doing the things they need to do to exclude people and even provide our nurses with what might be happening in town that we should be watching for. So.
Great, thanks, Jim. Does anybody have any questions for Jim? great.
If
Awesome.
you're interested, we got I just saw it came through the Maven training slides. There's a good question and answer section on it. I can share the email. The Maven help section, you don't need to be a Maven person to actually access the trainings and their training folder. So I can send that folder send it around through Janet. Again, they had today's or yesterday's. So they meet with the Maven folks, all the Maven users every Tuesday morning for training, just what's happening, what's updating the system. They make those slides available. If anybody's interested, I can certainly send those around.
Sure, that'd be great.
Sure.
Awesome.
Yep.
Okay. So we'll move on to exposure notification. Is Kevin here?
Kevin, you can unmute yourself.
Yep, I'm here.
Kevin, how are you?
I'm doing great. How is everybody else doing this evening?
Good. I'm looking at the attendees and I see a lot of the original
Crew.
the cat team.
Yes.
It couldn't happen. Couldn't be. So all right. Did we have some new info on the exposure notifications?
Well, so the exposure notification, Massachusetts on June 26th turned on something called Mass Notify. So the exposure notification has been officially turned on now for a few months in the state of Massachusetts. There was a good long rollout for this. They actually had code finished on this topic in the February timeframe. So they were, testing it in small groups. They rolled it out to either one of the cities closer into Boston and one of the colleges to kind of make sure that it was working appropriately, and did some fine tuning on it to make sure that everything was doing it appropriately. Got an opportunity to do some of the beta testing and walk through with the contact tracers, acting as a person that had gotten exposure. So we actually got to walk through and do what if scenarios with people and look at, some of the calls in and making sure that the contact tracers had the right questions to ask and all that kind of good stuff. So that happened May, June-ish timeframe. I'm sorry, April, May timeframe. So that was actually really good to kind of see how they were training people up and getting people turned on for that. So contact tracing, the automated contact tracing or exposure notification or Mass Notify is actually a piece of technology that started January, February of 2020. So it's been around a pretty fair amount. This form of contact tracing is an enhancement to the Department of Health or what you guys can have access to or what Jim can have access to. It actually goes into a different, when you get notified, there's actually an 800 number that comes up on your screen that you can actually go call and have that person you work with you, and they have a new entry into the Maven system on that. Jim, help me out here. I think there's actually a little field that says whether or not it came in through the exposure notification or not into the system. Is that correct?
There's a section in the Maven front page for notification. I haven't actually gone into there and seen what's being populated in those fields yet, but and again, we're kind of waiting to see how Department of Public Health wants us to handle this information that's coming in.
Mm-hmm. Yeah. So that's expected. That's the way that the system was designed, is to sit here and assist you guys as far as, finding other contacts that will come in through the automated system. So that's there. I actually have a short presentation that I put together to talk about it a little bit, about some of the technology and some of the features and stuff like that. If you guys want me to, I can give that really quickly, or if you have questions, we can just do it. Let me make it a little less formal. We can do questions and answers sort of kind of things. But that's up to you how you would like me to proceed.
I was kind of hoping that you might give an explanation of what this all is for people that might be watching.
Sure, totally. Okay, so it's actually really kind of easy. Let me see if I can share my screen. It's always fun. Right, we'll do that. And can you guys see my screen?
Yeah.
Okay, sorry, we're going to go low tech on this. I haven't done it as many times as Katrina. So getting into and presenting in Zoom is still a little nuanced for me. We use Teams at work, so we don't use Zoom as much. Okay. So what this is a presentation quickly on what is known as the Google Apple Exposure Notification Express, or GAIN-X, or just GAIN. Basically, it's a grouping of technology that has been integrated into everybody's smartphone, both iOS and Android systems. Those are your operating systems that drive your individual devices. So to allow exposure notification to help. So let's go to the next slide. And basically, one of the main concerns that we wanted to make sure right out from the get-go was obviously privacy protection. It's a really big deal. People don't like sharing where, in the United States, don't like sharing where they were 5 minutes ago or where you were a week ago, or let alone remember where you were. But that's something that's very important. So one of the things that kind of came out right away was that only public health authorities have the ability to write the apps and leverage the exposure notification infrastructure. In the United States, that was set up so that every state public health authority has that authority to grant permission. So in other words, the state of Massachusetts says, okay, we have the power, we control the keys that are granted from Apple and Google to turn this system on or off. So it is up to the individual states to go off and turn this ability to do exposure notification on or off in each of the devices. So it varies from one state to the next. However, that presents a very interesting interaction, because as small states up in New England, once the borders were reopened, people were moving back and forth between Connecticut, Rhode Island, New York, Maine, New Hampshire, Vermont, all of those individual states we were riding around in all the time. So instead, one of the things that had to happen on the back end, where all this information is being stored, and I'll get to that in a second, where the information is exchanged, I should say, that needed to have a centralized server. And there's a national server that's controlled by a nonprofit that's out there that does that. So that's good. That was a problem early on in the early days. One of the big things that is not there is that location data is not collected. That is verboten. That is not allowed. So GAIN exchanges only cryptographic keys. So the fact that the data with the protocol in your phone is exchanged just using a simple cryptographic key. Everybody understands that we may, like information for banks and things like that, when you're on your smartphone, it actually uses encryption to talk back and forth between the bank and your device. This just exchanges one of those keys, and think of it as a long series of ones and zeros, and that's what's out there for that. So again, this randomized cryptographic key is exchanged every day, or whenever you get in close proximity of another person, and a new key is generated every day. So one day to the next, even if somebody were to figure out your key somehow, a new key is generated each day, so that the ability to track one's whereabouts and all that other kind of good stuff, if you could even do that, is severely limited. The next slide. Come on. COVID test reporting is a user's choice. So not only do you have to opt into the system to turn it on, you also, if you do test positive and you want to report that, that is up to you as the individual to report that into the community. So that definitely happens. So so then the next thing is that GAIN-X automated contact tracing enhances the manual contact tracing. So this is another standard on this, is that it's not here to replace the Jim Gareffis or all of those other people that are out there with CTC or whatever. This isn't a replacement. This enhances what is already out there to provide more information to more people. So that way, if you meet the definition of the CDC's close contact, which you guys just covered, this device or the exposure notification protocol actually helps enforce that with what the CDC's definition is. So that's there. So this came out, and this is where we have both the Mass Notify. You can go to the website, mass.gov, Mass Notify. You can go there and search for Mass Notify on the mass.gov site, and it'll actually walk you through the process of actually installing it or activating it on your device. It's actually really quite easily. If you're actually on an iOS device, because that's all I have in my house, you just go to your settings page, you scroll down a little bit below general, and then there's something called exposure notification. You just simply click on that, and it walks you through the process of actually turning it on. And there's just this is what the enabling in the iOS and Android exposure notification looks like. On the left is the iOS, and on the right is what it looks like out of the Google Play Store to go turn on and install the exposure notifications that's there. The next thing is, this is what it looks like to enable the Gain app. So you can kind of walk through all of that stuff. So it talks about what the health authority is and what's happening with your data, and you actually have to give it permission to turn on. And then, hello. This is what it looks like on the iOS side, similar kind of things. But let's talk about the technology a little bit that's in here. What is actually used in here is actually Bluetooth technology. So the same technology that you use in your headphones is actually to transmit data between here and your headphones, is actually used to transmit, when this service is on, a single cryptographic key between two devices. So what happens is, very quickly inside the operating system, this phone will act as a transmitter and this phone will act as a receiver, and it'll transmit these cryptographic keys out if it detects that your another device is within that CDC area. And so those keys are actually stored on the device. Every 4 hours or so, the device reaches out to the server, the national server, to actually download the data that's been shared out there. And so then the close contacts are actually computed on your device. There isn't a central server like some other countries have set up. Singapore, China, and all those countries in Asia actually have set up central servers to do all the computation. Because this is privacy protecting, this technology that's in Apple and the Android, the Gain system, that's actually, all those close contacts are actually computed on the device. And so then once a close contact has been identified, if you have one, then you get contacted on your phone to start to take appropriate actions. So that's kind of there. We can walk through a scenario like that. Basically, the users, here's Alice and Bob meet each other for the first time and have a quick 10-minute conversation. Their phones exchange that anonymous identifier between the beacons, which change, as I said, frequently, which is typically one day. A few days later, Bob is diagnosed with COVID-19 and enters the test result in the app form from a public health authority. Again, that would be from the state of Massachusetts. And then with Bob's consent, the phone uploads the last 14 days of his keys from his broadcast beacons to that central server. That central server then collects all that information, and then at some point in time, in this case about every 4 hours or so, Alice's phone continues upon her day, not aware that she was exposed, but her phone in the background will periodically just download that information. And when her key and Bob's key matches, then that little alert will come up, basically letting them know that, or letting Alice know that she's had an exposure and what her next steps are to go off and do this. So that's kind of what happens in a nutshell. There's a lot of other technology that kind of goes into making this happen and work that I can get into and I'm very familiar with, but I don't want to bore the entire Board of Health with all those technology details that are exciting to a computer scientist like myself. So that's what's going on. Does anybody have any questions?
I'm not a computer scientist, so question: do when you get contacted by when you get a contact, are these people are they already contacts in your phone, or could they? is Bob and Alice, did they know each other at all?
So in the scenario that we have actually, that's there, Bob and Alice were just having a quick 10, 15-minute conversation, and that met the CDC's definition of a close contact. And then the system was activated once Bob said, hey, look, I'm sick. And so that was, that'll identify as a contact. The cool thing with this is that it remembers your contacts that were there, that you had, that were for that 15, the summation of, if you had like 3 contacts for 5 minutes that made the 15-minute summation in that 24-hour period, then that would be that would be say, hey, that's a close contact. You need to kind of go off and worry about it. Getting to your question about whether or not you need to, no, the answer is you don't need to have that person. So if you went to a concert somewhere and you had your phone turned on and a person that was sitting in front of you or beside you or wherever they were for a concert that you were jamming out to and having fun while you were there, and it was a 2-hour concert, you better believe that all those people that you have no clue whatsoever who they are, the phones will exchange those cryptographic keys. Now, you still won't know who that person is or the name, because all it says is on this day you had an exposure, and that's it. It doesn't say who, with, where, what, or anything like that. It just says you were exposed on this day, and that's it. Does that answer your question?
Yes. Yep.
Yeah, I think it's important to get buy-in, to have it be anonymous like that. I mean, otherwise, no one would use it.
Oh yeah, totally. It's not a tracking tool. So that let's be very forthcoming and upfront on this. It is not a tracking tool. Facebook, WhatsApp, any one of those types of things, Telegraph, all that kind of good stuff, actually have more access on your cell phone as a tracking tool than this does. This has nothing with that whatsoever. And in fact, there were some studies in Europe done with this. There was a guy in Italy that followed a group around constantly for a week and a half, trying to figure out how that he could use this technology to track a person. And they weren't very successful. So that's actually kind of a good thing.
Good. Mike, you had a question?
Yes, I'm actually interested since we've got a real pro here. Okay. A couple of weeks ago, a company for quite a while, there's a small company in Israel who's been selling very interesting technology that allows someone, including very wealthy individuals or whole countries, to do quite a bit of, shall we say, looking into other people's lives. Do you have any comment? I don't want to go any further with this, but do you have any comment on stuff stored on your phone, even cryptographic keys?
So what I can tell you about that company that goes out there, it's kind of an interesting piece of technology that goes out there from a computer science perspective. It's really kind of it's interesting from a study perspective, but from a exposure notification piece of technology, we worry about the data that's being exchanged and pushed around. So one of the things that this technology does is, as I said, the key actually changes every 24 hours. So you don't have the same key from one day to the next. So that's number one. The key length is over 2048 bits. So it's a very large key. And it's an Euclidean curve. I forget the name of the curve, but anyway, neither here nor there. It's a type of encryption that is used out there for that type of technology. But the piece that you're worried about is, could somebody then take the data that's on there and recover it and then match it? And the way that the data is exchanged, only the public key gets exchanged. Your private key never gets exchanged out there. So then all they're able to do, even if they did get that, Mike, would be to say, oh, look, he was standing next to this key over here, and it doesn't have any location data. So there's no data that they're actually getting that they can then go off and match. So that's a really good question. But the answer is no.
You want to bet? Never mind. It's all right.
No.
It's okay.
But this would be something, so getting back to this process a little bit about contact tracing in the schools and things like that, the generation that's currently out there called iGen, that's the 5-year-olds to the 22-year-olds, they have actually never known not having the internet next to them. And most of them have this binky that they carry around. This would be one of those things that I think could help out the school system. If you know, I've actually turned it on my kids' phones. If they're underage, a parent actually has to turn it on and say, yes, I agree to this and all that other kind of good stuff. But you can actually turn it on as a parent and send, if they have a device, send it with them into the schools. And, you know, because the schools are now saying, you know, keep it in your backpack. They're no longer putting it up in the little shoe cubbies that, you know, that they used to do. So it's actually much closer to the students. It's actually one of those things that we actually thought about during our design of this, was that what happens if you get like 30 of them together, because, you know, everybody puts them somewhere for when they're going into school, or, you know, what happens if they're in a locker and all that other kind of good stuff. There's actually a lot of studies that were done to try to figure out how all of this stuff kind of interacted and worked together. So, but turning this on for the schools, I think would be a bonus for people to help if there is a problem with some of the contact tracing within the schools.
Have you brought this to the school committee at all, Kevin?
I have not. They have not asked about it, but this is the first place to kind of start and talk is with the Board of Health. Hopefully there'll be a few members in the school committee that might be listening in, or maybe they listen in afterwards. There was an email that I sent last year to the school committee talking about this, and there was no further, there was no interest at the time. No one seemed to say, hey, yep, let's go turn this on or have that. So, but this is something that as individuals in the town, we could definitely, you know, individual responsibility, go turn it on. It takes a full 2 minutes to go through the process and turn it on, and it'll be helpful. And you're, you know, helping out your neighbors just by carrying around your cell phone in your hip pocket.
Great. Is Justin on the, Justin McCarthy? See Allison.
I don't see Justin McCarthy.
I know, but sometimes he goes under Allison's. Just wondering if we can smooth that transition, maybe get you into seat. Go ahead, Kevin.
I wonder if we could put a link on our website that'll point people to the Mass Notify about how it works, the mass.gov site. There's a little video up there. Might be helpful to include a link just as the contact tracing collaborative sort of winds down. It might help Jim. I don't know.
Yeah.
I think that's a great idea.
Kevin, can you forward that to Janet and maybe see if Janet can get that?
Yeah, I can put that right on.
Cool.
Great. Any other questions or discussion for Kevin?
Thanks, Jeff.
No problem. Anytime.
I appreciate it. Thank you. All right. So we're probably really behind. Oh, yeah. Sorry for the 7:30 discussion on sector-specific standards for the mask mandate. I did a site visit on a really unique business at Woodshed, and was wondering if we could possibly discuss request variances or approve variances for certain site-specific businesses. I know it's going to open up a can of worms, but with, Jim said that he had some information about sector-specific standards with reopening. So just want to see what you guys thought, because I know we also had something about a correspondence about exemptions. Where is it? Cut off something about houses of worship too. So
Lisa, if I may start.
yes, please.
So when Lisa asked me this question, what I explained to her is that you do have a set of regulations. The regulations don't really have a mechanism built in them for granting variances. So one of the first steps you'd need to do if this is something you wanted to consider was to, amend those regulations to provide a mechanism for people to request a variance. And typically, if you look at in Massachusetts, there is what they call an administrative code, both for environmental regulations and for public health regulations or sanitary code regulations. And that administrative code really are instructions to boards of health and how you do things like grant variances and hold hearings and notifications. And in there, it kind of describes how a board might approach the consideration of variances. And essentially, there are two main components to variance considerations. One is the applicant for the variances needs to show the board that there's some kind of manifest injustice being caused to him based on that regulation. And the second thing is they need to show how they may be able to meet this intent of the board's regulations by doing something different. So you need to show that this is really impacting you. They use the term manifest injustice. And how can I provide the same level of protection or whatever it is that the original document, the original regulations, it was set out to provide. So that's when you're looking at that, that's what you really want to consider. So to open up a variance process, I'm sure everybody can come to you and suggest a manifest injustice, and they may even be able to provide for you, the ways that they may mitigate things to offer the same level of protection that you wanted to achieve in those regulations. As I mentioned to Lisa, I'm not an industrial hygienist. And so though I do have a sense of aerosol science and how air moves and concerns and things like laminar flow and stuff like that, I'm not sure I would be the best arbiter for every one of those situations. So what I suggested to her is that the Division of Labor Standards during the shutdown of the state, essentially during the emergency orders, based on the phase of reopening the state was at, had sector-specific workplace safety standards for many operations. And in those sector-specific workplace safety standards, there are four main categories: operations, sanitation. I figure out we haven't dealt with them, but in one of the cases, they covered the requirements for masking. And so when the state had a mask mandate in place, the only exemptions allowed for the state mask mandate were those that were built into those sector-specific standards. So, for instance, the office place standard had I don't want to say an exemption, but a carve-out, if you will. Essentially, if you're in your own space, you didn't have to wear a mask. So they had those kind of things addressed in those. Not all standards had mask considerations in them, but gyms and health clubs were one of those sector-specific standards that did seem to address distances for masking for people indoors. So if you're going to consider variances, you'd have to modify the regs. And then if you were looking for a standard, again, unless you want to try to go through every iteration that you might use those as a basis for considering a variance. They're something that was established by the state, by Division of Labor Standards. And they were used during the worst of the pandemic in the state's reopening process. So again, if you want to consider a process, that may be a basis for considering variances, if you will, by using those workplace safety standards. I mean, you may have a variance process in place, and you may say, well, if you can achieve whatever stage, and all of these documents. And again, the other good thing is all of these documents are archived on the state website. So you can go back and take a look at in phase 1, 2, 3, 4, whatever the case may be, the state modified those sector-specific standards based on what was happening in the state at the time. So again, it's a very transparent way to maybe address some of these if you wanted to. Now I've talked too much. I just figured I would.
No way.
I explained the background for that. So
you explained it way better than I could. So does anybody want to entertain any discussion on this, or do you want to just stay with the strict regulation that we've made, or do you want to allow how would we change the regulation, Jim? Would that go back to, if we wanted to do something like this, would we have to go back to town council and adjust it?
So what you would need to do is you'd need to add a variance section to your regulation. So, you'd need to, at a posted meeting, have it on the agenda for amending your regulations. Bring up the regulation, discuss it, vote on it, to have it included, and then publish it like you did the original, and then it's in your regulations.
Okay. Go ahead, Kevin.
In this specific instance, I believe we're referring to semi-indoor gym facility. And I'm wondering, instead of just amending regulations to allow for variances, if we can just refer to the number 3 or whatever number it was in regards to those facilities, and amend that point to refer back to some sector-specific standards set by, Division of Labor at X amount of time, whatever the verbiage is there, instead of adding in the piece about variances.
Again, I think just to be amending your regulations, and if you wanted to put that caveat in there saying,
right,
these operations can operate with the mask requirements in this particular sector specific. I mean, the nice thing is, again, I looked tonight, they all seem to be up on the state's website in the archive section.
Okay.
So it's something that somebody could go to. So if somebody had a question about what that means, you could certainly go and look at the document, and it's in the language of the document.
Understood.
Anybody have any other,
Lisa, while I'm unmuted, I was also wondering if the board had an appetite to amend the regulations in regards to people in restaurants actually sitting at a table with their party being able to be unmasked.
So they're sitting, yeah.
right, yeah,
I don't have no problem.
I think that's a reasonable, to the regulation.
And maybe we should, I don't know, talk about it.
Right. Tonight or another night?
Or another night, public hearing. I don't know.
Okay. Gino or Dan or Mike have any issues with that or comments?
Yeah, like Kevin, when somebody goes to the restaurant, they have a mask, and when they sit, as long they feel comfortable, 2 feet, whatever, and then they can take the mask so they can enjoy their meal and so forth. And when they're gone away from the restaurant, before they leave outside, they
When
put
they're
the
out of their
mask.
seat, yeah.
Yeah, and then they can take the mask out when they are outside. That makes sense. But we can discuss this.
Okay. And I think the fitness center, we went back and forth about simulating an outdoor environment.
Right.
Outdoors. I think that sometimes they can actually achieve that with ventilation. So go ahead, Mike.
You have a comment to make. The purpose of the mask mandate is to add to the, frankly, the vaccine and distancing and the other components to reduce transmission.
Right.
And the minute we take a step into what we call granting variances at this point, given the fact that we have a certain population of around us that are vaccinated, and yet we're running cases. My suggestion is that we might limit our thinking, not thinking, but our sort of a model, stick strictly to what will things look like if we limit our variance scope to what we'll call health-related activities. Just health-related activity. That's a can of worms. Who decides what's health-related? It may be easy for me, but probably hard for Kevin. But he's younger, so it's hard to know. Okay, so my concern is that the mask mandate is not a permanent fixture in our horizon. Okay, we have to remember the purpose, and also we have a termination or something to look at. Two sets of metrics that tell us where we are and whether or not that we've run the mask mandate as far as it can go, and maybe it's having an effect and maybe not. We've just started. In fact, technically speaking, until the school started their testing program, which was Monday. Okay. Yes, we've had the mandate in for about a week to 10 days. We've barely started. And
You're right.
I'm not expecting miracles. I don't expect numbers to fluctuate just because of the mandate. The idea is to protect is basically to keep the spread as minimized as possible. I have no difficulty having discussions about variances, but I think we're doing this probably a little early because we're also facing not a grave, but a difficult situation emerging I suspect near the end of October, when I don't know what it's going to look like at the end of October, but that's when the school basically, as far as the state is concerned, may or may not terminate the masking order and other things that are in place for the schools.
September, yeah.
Well, it's the end of
1st.
October, yeah.
October 1st, the schools.
So, I'm not saying we shouldn't have a discussion about variances, but I'm saying that we don't really understand yet. It's very early in the game to understand where the town and the state is going. We sure as heck know where the country is. Okay. We know where Florida is and all those other kind of places, but we don't know where we are. We look good some places, not some others. Littleton looks very, very good. And I don't want to have our population feel that we're letting them down. Let's put it that way, and taking our foot off, basically not going full speed ahead with the technology and science that works.
Okay. So continue the discussion, get a little bit more guidance and a little bit more data.
Yep.
Gina or Dan, did you have any comments, concerns?
I think probably, Mike, as a point, maybe we should wait until October and see how it goes. Then we can make a decision. Let's see what happens.
Okay, so we'll continue to discuss the sector-specific standards for the mask mandate at the next meetings.
Yes.
Okay. All right. So shall we move on to administrative matters now?
Go ahead.
Go ahead. Sorry.
Yes, please.
So I got something. Have we decided, Janet, what is happening with town meeting this fall? Is it going to be indoors or outdoors?
I haven't heard anything about it, actually.
Does anybody know?
They're talking about maybe outside, but the question is, it would be better if we have it inside.
Because there was a correspondence from Kim Mayo talking about Harvard's October town meeting is outdoors.
Right.
So, all right, I guess that's probably up to town administrator.
Well, the Board of Selectmen, actually. Yeah.
Okay. All right. Does anybody else have any correspondence that they want to know? That Kevin Baker did a lot of replies last week to a lot of the correspondence that we had that requested information. And then there's another one I haven't gotten to, a voicemail from Andrew. And again, he wants some information about houses of worship and the mask mandate. So
I believe he wanted an exemption on religious grounds.
I explained to him that the board's regulation didn't have a provision for that he needed to talk to the board.
okay. So is he happen to be in the audience at all? Okay.
What was his name again, Lisa?
It just says Andrew. It was a voicemail that you sent.
Yeah, I spoke with him twice, and he said he would make an attempt to come here, but I don't see him in the audience.
Is it a religious for just himself, or for the? Did anybody know? Maybe Jim, do you know? Was it just for himself, or was it for the house of worship? That
I think it's for him based on his religious beliefs or his religion that looking for an exemption from wearing a mask.
Just as a one individual,
right?
Not as, okay.
You might be interested to know that. I mean, this may be worthless, but you might be interested to know that there is, in fact, none of the major or minor religions in the United States has put out a formal statement or informal statement that forbids or allows, just, shall we say, has reasons for not adhering to masking. And the civil rights rules for the United States also don't have those.
All right. There was another-
So he, the best thing to do is ask him to consult a lawyer. We're not in that business of advising.
Anybody else have anything that they want to bring up?
Well, when I go to church, everybody has a mask, so they understand. And then they're between 2 to 3 feet away from each other. So far it's working very well. And for some reason they blame me for that. But I said, no, wait a minute. I'm only trying to help you guys out. So, and the church is almost full, but to a certain limit. I mean, not like it used to be before the pandemic. But they're trying to keep a distance. They put a mask on, and that's it. And then they go out, they take the mask out.
Mm-hmm.
Thank you, Gino, for doing that work. That's tough.
Oh, it's nice for me to get blamed, right, Mike?
No. I think that you and your folks are doing a great job. I just want to relay as a board member my appreciation for it.
Yeah.
They're leaders. They're leaders.
Yes, sir.
Okay. I'll get to you, Janet, in a second. Kevin, did you have your hand up?
Oh, I just wanted to refer to those Mattawanakie bylaws. Jim, I don't know if you saw those. I don't know if that helps or hurts, or if it could just go to the zoning board now and we don't have to deal with it.
Well, typically association bylaws, the association is the one who has the authority to enforce those.
Okay.
So I went out and looked, wrote the gentleman a letter. He hasn't responded. I did stop by the house to talk to him the day after I did the inspection. I can stop by, see if I can catch him and have a conversation with him.
So in regards to the bylaws, he just needs a copy of those with number 4 highlighted and put it in his mailbox. And
I could certainly send him a copy of that, but it really would be the association to enforce that.
Okay. Because that would make things easier.
Who is are you in touch with the associate? I know we got this from the secretary, but is
yeah, I would just reply back to her.
Okay.
Yeah.
All right. Janet, you had something you wanted to add?
Just in addition to talking about Kevin responding to some of the correspondence, I wanted to make sure that people are aware that we've also included those letters on the Board of Health website. So if you go to the Board of Health website on the Town of Littleton page in the upper right-hand side under news and announcements maybe, but news is also a link to those letters that Kevin wrote so that anybody out in the audience who wants to read it can see those there.
Right. That's the gives all the scientific data as to where we get our information from. And I think Katrina expressed that very nicely tonight with, her resume and where she gets her information from. So not just picking it out of the stratosphere. So, all right. Any other correspondence anybody needs to discuss? Any member comments?
Everything is fine. Thank you so much.
Okay. Any public comments?
No hands are raised.
All right. So we'll move on to the minutes. I got a chance to look at that. I think, I have an issue with the 8th, September 8th, but we'll do the 30th. Motion, anybody wants to make a motion to accept the minutes of Wednesday, August 30th, 2021?
Make a motion to accept the minutes of August 30th, 2021.
Thank you.
A second.
Great. Do a roll call. Kevin Baker.
Kevin Baker, yes.
Gino Fratelloni.
Yes.
Dan Kane.
Dan Kane, yes.
Mike Zeldin.
Mike Zeldin, yes.
And Lisa Flanagan, yes. And then I think, Janet, on the 8th, the 7:30 discussion on Wellington. Oh no, what was the one that we had to accept? We recommended that they put the sieve analysis in as a variance to our local reg. Was that Dogwood or?
Dogwood, yeah.
So
Broadman, was it Broadman?
Broadman.
John Boardman.
Yeah, Boardman, sorry.
It says he was told a sieve analysis was used. Can we say that we recommended that he change that and add the sieve analysis as part of the variance?
Mm-hmm.
That was the only thing that I had. Anybody else? All right, so we'll do, is there a motion to accept the meeting minutes for September 8th?
Make a motion to accept the meeting minutes for September 8th with Lisa's addition of the sieve analysis into the variance request.
Second.
Great, and we'll do a roll call. Kevin Baker,
Kevin Baker, yes.
Gino Fratelloni,
Yes.
Dan Kane,
Tim Kane, yes.
Mike Zeldin,
Mike Zeldin, yes.
Lisa Flanagan, yes. Great, so next meeting will be, what, I think you said it on the
October 13th.
October 13th.
Motion to adjourn?
Unless needed. Great. And go ahead, Mike.
I'm happy to announce that if you're 65 or older and you've had the Pfizer vaccination, you are now qualified to get a booster. The FDA approved it this evening.
Oh, great.
November, they're gonna get it.
Starting in November or
Yeah.
right away?
Details to come later. Dance cards to be submitted. Yes.
All right. There you go, Jim.
Well, we'll see what Department of Public Health has to say next week as far as a process.
Awesome. All right. Yep. One motion to adjourn. Did I have a second?
Second.
Oh, it's a tie. But we'll do roll call anyway. Kevin Baker,
Kevin Baker, yes.
Gino Fratelloni,
Yes.
Dan Kane,
Dan Kane, yes.
and Mike Zeldin.
Mike Zeldin, yes.
Lisa Flanagan, yes. All right. Great.